Welcome, everyone. Welcome to the Implementation Toolkit for Small and Sick Newborn Care webinar, Safer, Speedier Referrals for Maternal and Newborn Survival. Welcome. Please introduce yourself in the chat. Bienvenue. Please introduce yourself in the chat. This webinar is being translated to French, and on your screen now, you'll see an interpretation globe that you can click to be able to translate this webinar from English to French. Next slide. Welcome once more to this Newborn Toolkit webinar on safer and speedier referrals. Just as a way of a reminder, the Newborn Toolkit is a multi-country, multilingual learning for high-quality small and sick newborn care. In 2025, we had more than 62,500 unique users visit us, and we hope that this continues growing as the years go on. We have tools in more than 1,000 tools in 15 languages, technical content in French, and also this is all to meet the national target for SDG 3.2 for newborn survival. Next slide, please. Welcome once more to the Implementation Toolkit for Small and Sick Newborn Care webinar, which is based on the WHO UNICEF core components that you see on the screen now on this globe. So today's topic is on safer and speedier referrals for maternal and newborn survival. To join the Newborn Toolkit to hear about webinars, news, and share tools or ideas, please do sign up to our Toolkit newsletter. So we have a QR code on the screen. We also have a newsletter in French, and you can follow us on Blue Sky, Twitter, LinkedIn, and Facebook. Next slide. So upcoming webinars, on 12th May, we have a webinar linked to World KMC Day. And on 16th June, we have a webinar linked to the leadership and governance topic, and the focus is on newborn networks. And we have many, many more exciting webinars to come that you can find on our website. Thank you once more for joining us on this webinar. My name is Mbozo Sipalo, one of the Newborn Toolkit co-leads. And now I will hand over to Lauren to take us through the webinars with a French touch. Over to you, Lauren.
Merci. Donc, bonjour et bienvenue à tous nos participants parlant français. Si vous voulez écouter le webinaire en français, s'il vous plaît, cliquez sur le bouton de traduction situé sur la barre du menu de Zoom pour accéder à la canal français. Donc, on a aussi quelques webinaires à venir. Le 14 avril, un webinaire sur les systèmes de référence et lien avec les soins maternels. Et sur le 16 juin, un webinaire sur le leadership et la gouvernance avec les réseaux néonatales. Donc, nous vous invitons à nous rejoindre pour ces webinaires qui viennent. Next slide, please. And I would just like to introduce our host for today, Dr. Loveday Penn-Kekana. She's an assistant professor at the London School of Hygiene and Tropical Medicine, coordinator of transport and referral community of practice. If you're interested in joining, we will share a link in the chat as well. Her background is as an anthropologist with content expertise, especially in maternal and transport referral systems. So we're very excited to have Loveday with us today, and I will hand over to her to take it from here.
Okay, and thank you very much. Thank you very much to the Nest 360 team for inviting those of us who work in this area to present. I think referral is a very sticky and difficult problem, and it's a key part of the health system. And it's really exciting to have all these presentations today that are looking at how we do it and how we do referral, which is safe and speedy. If possible, in an ideal world, we would have as fewer interfacility transfers as possible, but we are always going to need to have some. Okay, so I wanted to start by, I think, moving on to our first presenter. So from WHO, Dr. Lee Allen Wallis, who's going to talk a bit about the WHO approach to safer referrals. Thank you very much, Lee.
Thank you very much, and thanks for the opportunity to be here. Bonjour à tous. Safe referrals. So there's lots of teams at WHO that have referral within their remit. maternal and child health team, obviously looking at safe referral and effective referral for mothers and children. And across the life course, for example, the mental health team would be looking at safe referrals for mental health. Our team, the reason I'm presenting today, we have a responsibility for things like models of care and the packages that are delivered at different levels of the system, and also for guidance and norms around the pre-hospital system and the emergency care system. So I'm coming at it from that perspective. I have got some information here specific to maternal and child health from that team. I'm speaking using their materials in part. So let's go to the next slide and start just by saying what referral is when we're thinking about this. And I know the team will drop this into the chat. I would recommend that you have a look at this if you want to think more about referral and how you should structure a referral system and what needs to be in place to do it effectively. So this is Mary Plummer's part of our team. Terry Reynolds, the last author there, is my boss. And they've been looking at the essential components. But just before we start, even with the thinking about the system, we think of referral as the targeted direction to a facility or practitioner for a specific health need, but it goes in two directions. So we're not only thinking about referral up, there always needs to be counter referral to have an effective system. Next slide, please. So I'm not going into detail in any of this, don't worry, but these are some of the tables from this publication just to frame for you that if you think about an effective referral system that needs to be in place before you can do an individual patient transfer or provide care in referral for any individual, you have to have the system in place. And to do that, there are things that need to happen at the national, subnational policy level, the system level, and then there's some things that need to happen at the facility that's initiating the transfer and the facility that's receiving the patient. And they may be primary care and secondary care, or it may be different levels. And you can go through this, and please, I'm not here to take you through 30 items in a table, but there are some really important pieces that come out again and again in the literature that you have to have in place in order to have an effective system. And if you are working at the policy level, I'd encourage you to look at the top part, but if you're working in a health facility, then think about whether you have these things in place. Do you, for example, once you've received a patient, do you have a mechanism for communicating back to the referring facility to tell them what happened and how their patient went on? And was it a good referral? Or do you only ever do it when there's a problem and you complain to them? So this question is like that. Next slide, please. We also then looked at specific issues that need in place for counter referral. So there are some examples, and most of these examples, as you'll see, come from the maternal child health world. But you really need to have training and protocols and so on explicitly for counter referral so that patients don't just come up and get to more and more complicated and expensive care. They also go back down closer to primary care, closer to where they live. And that should be in place even if it's an emergency patient where their first point of contact is the emergency unit or emergency department. Next slide, please. We also look specifically at some of the digital health tools that you might want to have in place, including, for example, the use of AI. So next slide. So using e-health, using electronic medical records, and using electronic communication systems to make sure that your system is effective. Next slide. And then the final piece from this one paper is just some, excuse me, about using, for example, digital health referral coordination. So again, I would really encourage you to go look if you want to know more about any of these areas: counter referral, effective inter-facility transfer systems, or ways of supporting this digitally. There are multiple examples that all reference, and you can link out and read, particularly in the maternal child health world, you can read about how people have done this and good examples, good practice examples. Next slide. And next again, thank you. So moving away from that, just to frame that we think about the emergency care system, the acute care system, this would also apply, and I'll show you in a second how Loveday's and team have applied this to maternal child health. This can apply to different, you could put any disease, condition into this way of thinking. So there are things that should happen at the scene, the incident. There's things that should happen during transport and things that should happen when you arrive at the facility. And ideally, as Loveday already said, you should go to the right facility in the first instance. You don't really want to be having to do inter-facility transfers, but we know, both from my personal experience in South Africa for a very long time in the ambulance system, but also from published data, that about 30 to 60% of ambulance work is in well-established systems is inter-facility transfer. So it's a huge strain on the system, and much of it is related to somehow, in speech marks, being at the wrong place for the care that you need. Next slide. So we'll drop you a link for that infographic, but this is something that's being developed to try and make that apply specifically for maternal child health. And Loveday, I'm not ignoring your email. I'm aware you sent trying to apply something similar now to interfacility transfers and think about the core components of that so that it can be part of toolkits to really get effective transfer of pregnant mothers, or less ideally, but we always want to transfer in utero, but less ideally transfer in a newborn. Next slide. So our maternal and child health team have been working a lot on how you apply these principles specifically to delivery or to the peri-delivery period and newborn period. We, in our team, have done work generically. So there's a QR code. You can find a lot of resources. We've got there's a little bit of clinical content there, some clinical algorithms, but it's mostly operational. How do you actually put a pre-hospital system in place to deliver the care across all sorts of conditions across the life course, whether it's pregnancy related, something to do with aging in adolescents, or to do with specific disease conditions. Next slide, please. And in the toolkit, you'll find that there's a system level assessment tool, and there's a service level assessment tool. And to allow you, it's not really interested in the assessment itself, but what do you do with the findings? So can you ask specific questions, in this case, about the ability to do transfer between facilities to identify improvement strategies? So at a national level or a subnational level, we have questions in the assessment tool about the ability to do criteria, and the ability to do transfer and the presence of criteria. So you want to get to the point where at number 5 there, you have system-wide transfer criteria in place, and you're monitoring them and you're reporting against it, so on, and you've got a quality improvement system in place. But most systems will be somewhere at 1 or 2 or 3, and that allows you to develop an improvement plan. Next slide. At a particular ambulance service level, we have it's called PEAT, the Pre-Hospital Emergency Assessment Tool. There are a number of questions you can ask the service itself about its ability to transfer patients between facilities and about how effectively communication happens between those facilities. And again, not for the point of doing a report, but for the point of developing an improvement plan. Next slide. Beyond the assessment and the improvement planning, as I said, we have a lot of operational materials that are in this manual, this pre-hospital emergency care guidance. So I encourage you to look at that through that pre-hospital toolkit website if you're interested. And on to the next slide. Part of that, we have a referral and transfer component, and you'll find these forms on the website. These are not specific to maternal child health. And in fact, as you'll see in a minute, we've been working with the maternal child health team to try and make these into something that's much more appropriate for the population that you're interested in. But we use these, so we have 3 forms. One is for the initiating facility to refer a patient safely. It takes you through the information that the receiving facility needs to know. So you would use this as a clinician at the facility that's referring up. Usually this is not for counter referral. Next slide. We also have a checklist before you transfer a patient to make sure that you have everything in place that you need for a safe transfer of the patient. We may often think that that's the ambulance crew's responsibility, but as clinicians, it's also our responsibility to make sure these things are in place. And next slide. And then we have a transfer checklist for the crew, the ambulance crew are actually doing the transfer. So as I say, these are general. This is for every patient. Next slide. The maternal child health team have worked on this impact which is due out very soon. I'm just in communication with the team. There's some questions came back from review. There is a specific chapter in there about referral and transfer and using these 3 levels of basic, comprehensive, and intensive EMOC as the different levels, and then making very clear recommendations about what is needed for safe and effective transfer. So I want you to look out for this coming out. I think this is going to be incredibly important in terms of safe transfer for pregnancy and childbirth. Next slide, please. Just as examples, these are not, please don't like me screenshotting these. These are samples that are dropped into the chapter. And as I say, the team's working on trying to make the forms that we've got, but trying to produce specific ones for pregnancy for newborns. But at the top left, you see just an example of a maternal referral form. And at the bottom right, it's a counter referral form. So making sure that you get that feedback. Next slide. So hoping that would be out within the next few months, and if that's the case, then I'd encourage you. It's going to be an incredible resource, and it's also, it's a big manual, multiple chapters across the whole of pregnancy, so really important work. But this is just another checklist that is in there, still in the pre-final form, about questions that before you transfer the patient. So questions about the mum, questions about the newborn, for the initial care and after initial care and before admission. So this is going to be a really useful resource, again, to take that sort of generic form that we've developed and to make it specific for your population group of interest. And next slide, thanks. I'll leave it there. That was a quick rush through. Again, I wasn't trying to give you the fine details, so you could say, this line item is in one of those checklists. I want you to go look at our resources in terms of the ambulance system overall and referral system overall, whether it's about how to put a referral system in place and the components, or some very granular operational information. And then to just flag that this work is coming from the maternal child health team very soon, and it's going to be a very important resource for you. Thank you very much for the opportunity.
Thank you very much, Lee. And I would say, as someone who works in this area, I think a key lesson that I've learned is it's really important for the maternal and newborn people to talk to the emergency care people. And sometimes they have, even though they're serving the same populations, they sort of operate quite independently. And it's really good that all this work is happening to try and bring these 2 communities together. So there's not just the impact document, but the maternal and newborn team are hoping to come up with health system norms around care during transport. And then in the EMOC revisioning, this idea of the EMOC signal functions for how you decide what level you are. It's now going to be that to be able to be an EMOC facility, you should be able to arrange transfer with care during transfer. So there's a lot of work that's happening, bringing together these 2 communities. And if people are interested, please contact me or contact Lee. And also, I would really recommend going to the WHO webpage, the emergency care people. It really makes you think a bit differently from how we think in normally maternal newborn health. So thank you very much. I'm now going to ask my very impressive colleague to present on his work, which looks at this challenge from a slightly different issue, which is around sort of how we look at travel time and estimating travel time and these issues. So Adura, would you like to now present?
Thank you very much, Loveday. You're very kind. So good afternoon, everyone, and good morning, good evening, wherever you are. My presentation is titled Innovative Geospatial Data for Maternal and Newborn Health Referrals in Africa. I'm really grateful to Lee for sort of setting the stage right there. And I will try to sort of set the scene specifically in the context of geospatial data. How do we define this? For those who do not know, geospatial data is information linked to specific locations on Earth that combines some form of coordinate geometry. You would know that as latitude and longitude with descriptive attributes and time being very critical. And the WHO has sort of moved from time to time over the last couple of years, back from 2009 when the EMOC guidelines, recommendations was initially put out, where at that point it said you needed most women living in communities to be between 2 to 3 hours to the nearest comprehensive emergency obstetric care facility. Then that moved on to having it about 2 hours. In the Lancet Commission, we talked about 80%. Then more recently, we've moved to 1 hour. And now we are talking about 30 minutes of interfacility transfer time, which is very key to the discussion that we're having today. And this is quite evidence-based, building on work that has been done in research that has shown that about that 30-minute time slot is the critical time point where you need to make sure that a woman is getting to care. So different methods have been used to sort of assess geospatial data for maternal newborn care. I think before we go into the specific methods, it would be good to highlight what an ideal method should look like. It would make sense that we want such methods to be reflective of reality, to capture that complexity of journeys that Lee was showing earlier. I think a clear distinction between maternal newborn health emergencies is that you would hope that you're not having to do a C-section by the roadside, okay, or to deliver a baby by the roadside. If you're having to do that, something has gone incredibly wrong. So you would want those methods to be able to capture the complexity of the journeys to care. You would also want it to reflect the facility capacity to provide care. Again, another key distinction with other forms of emergency is if you have a road traffic accident, you know where to go. You don't go to a primary healthcare center, you go to a hospital. But when it comes to maternal newborn health emergencies, you might want to go to a PHC because it's nearest to you. It's not really just yet an emergency and so on. So again, you would want any method that you're going to use for this to reflect the capacity to provide care. And finally, you would want that method to be scalable. Okay. All right. Moving on. As I mentioned, there are a few different methods that have been used over the last couple of years. We started quite very um, basic by doing what we called Euclidean distances. This is as the crow flies. So straight line distances, this is where the woman lives. This is the facility, draw a straight line. Or this is the facility she's coming from. This is the facility she's going to, draw a straight line. But of course, we know that that is not reflective of reality. Then we went on to network distance. A very common one that has been used over time has been this least cost pathway to care. And then finally, this sort of gravity model. I'm just going to mention this. Then we moved on. This was with engagement with WHO colleagues from the University of Geneva, led by Professor Nicholas Ray, to access mode, which built on the least cost pathway method, but brought on top of it local insights by bringing people together who live in those areas to talk about some of the transport constraints that could be fed into the model. More recently, however, we've moved on to a different method where we now leverage, next slide, please, Google Maps, which I'm sure many of you would have used to get to somewhere at some point in time of the day, maybe this morning or later in the day for you. But we use this tool to sort of navigate the world. It combines data from satellite imagery, from reports, and government-generated data to advise us on how we move forward. This has not been used quite widely. And next slide, please. And we before using it, we try to sort of show, how close to reality would be estimates from this different model. And we talked about the ideal characteristics that we would expect. And this is on the right side, you'll see this is called the box and whisker plot, which you'll see that we had some of the models that I showed earlier, the cost friction being on top there, and then you have Google Maps in the middle. And then in this work that I led, we had two drivers try to replicate the journeys of women to care. And this included women who either went directly to a health facility or those who had to travel to a facility before going elsewhere, i.e., they were referred. And you can see very clearly that the models were, these are the same group of women. The models were not as reflective of reality. The closest to it was using Google Maps. Moving on, please. So just to give a few examples of how this has been used practically now in Africa, and I'll focus on the ones that have greater policy utility. Next slide. So, for example, here in this work by Schmitz et al., they try to look at referral transit time using the least cost pathway, but also getting local insights on transportation and communication delays and adjusted for that. So they linked facilities that did not have capacity to provide the service to those which had that capacity. And what they found was that more than half of all referral peers in Kigoma region have travel time delays nearly exceeding 1 hour. And that facility peers, referring to facilities providing higher levels of care, also have large travel time delays. Next slide, please. And then with access mode, which Nicholas and his team have been leading, this was when they used this approach in Benin Republic, and it was a national survey. On the left side, you have the facilities before they did any prioritization. And on the right side, after conducting workshops to prioritize a set of EMRI facilities that could provide services, and added on top of it local insights of based on travel characteristics, they were able to identify, next please, 109 facilities that were then prioritized to be able to provide care going forward in those settings. So in countries where you had minimal resources, this would be a very useful tool to prioritize which facilities should be selected going forward. Next, please. And then finally, I present work from my team which we did in Lagos, where we actually replicated the journeys of women to care using Google Maps. This is the third example now. And every red dot you see there represents where women have had to travel more than an hour, 2 hours to get to care. And those were called hotspots. Taking this data next was used to then identify those specific hotspots and used to decide where to situate new facilities. One of them is this one that I show on this slide, which has the Honorable Commissioner for Health in Lagos over there. And one of the hotspots in Ojo was that evidence was used to inform the decision to site a facility here specifically. This example, next please, is based on retrospective data. So what people have actually declared of where they travel to. We've also used it prospectively, assuming that every single point on Earth where people live is a point where they will need to travel to care, or where potentially a facility might be based. And using Google Maps, we're able to go granularly to identify specific areas. So while this entire area might be averaging about 35 minutes to get to care, you can find that when we then disaggregate it into specific communes or wards, we can find the specific trouble spots within that area. Next, please. And then we're able to use this to show travel time at different, based on going to the nearest, second nearest, and third nearest. Next, also showing travel at different times of the day. And we're using this also right now to show interfacility travel time, trying to replicate complex journeys of women to care. Next, please. Okay, this evidence is available and this data set is available on this digital dashboard, which we've done with colleagues at Google, and is finally now being scaled up to multiple countries in Gambia, Ghana, Uganda, and elsewhere. Okay, next, please. Okay, and it has also been used to inform where community health workers who are supporting pregnant women are based. Next, just a quick reflection on what the future looks like. And I'll just quickly flag this in 10 seconds. Now we're trying to look at this in the context of AI and developing what Google calls a population dynamics foundation model to inform what travel time would look like and be able to use that to predict interfacility referral travel time and optimizing that going forward. Last slide. Thank you very much.
Thank you very much, Adora. And I would really recommend to everybody they look at his work. I mean, one of the things that Adora's work has really taught me is I think I always used to think that access challenges existed in rural areas. And Adora and his team have done a lot of work in sort of big urban areas and slums that have shown that you really need to work in this area. And then I just wanted to make one other quick point, which I think we also need to think about, which we haven't really got presentation on, although the next presentation will cover it, is cost. So you're talking about travel time, but often really big delays are in the family managing to get the funds to pay for the transport, and similarly when they get to the facility, how quickly they're cared for. So that brings me on very nicely to the next presentation from India, which teaches all of us so much about ways to do things. So Dr. Rao, can I ask you now to talk a bit about your work with neonatal ambulances?
Sure. Greetings from India and namaste to all of you. Thank you so much for inviting me to this talk. Can I have the next slide, please? I represent the organization EMRI because in India, the ambulance services are organized in public-private partnership with the respective state governments, but the funding is from the federal or the national government. Next one, please. So over the decades, what we found, there is a steep decline in the neonatal mortality rate. However, our aim is to reach less than 10 by 2030. India still contributing significantly to the neonatal mortality at the global level. So in India, we are running exclusive neonatal ambulances. Next one, please. In 3 of the 19 operating states, and you would appreciate from the pictures, respective state governments will also have a separate way of showing off their own projects in the respective state, because health is a state subject here. And you will find in 2 South Indian states, we have 65 and 33 ambulances, which would mostly refer to 1 neonatal ambulance exclusively for IFT per district. District is an administrative unit where the population may be about 1 million to 2 millions. And the patient compartment area of the neonatal ambulance looks like this, with an incubator and the other paramedical equipments which are important, and there are some standards laid out under the national AIS code, and we have our own experience of identifying the right equipment and consumables for each of the neonatal ambulances. Next one, please. This slide talks about the drugs what have been identified from the Ministry of Health and Family Welfare. Some we have picked up from the global literature, including WHO, and finally the National Neonatal Forum, and our own experience of running the ambulances for the last 2 decades. So we have identified equipment, consumables, and then next one, we have also ensured that we will have a close monitoring of the services because we work with the governments. So we have a very huge technology in place where we'll be able to provide information on what is happening at the daily level, what is happening at the monthly level, and cumulatively what we have been doing in each of the states in terms of neonatal ambulance related. And I just wanted to again emphasize it is inter-facility transfers, mostly from the secondary level neonatal institute called sick newborn care unit to neonatal intensive care unit, which is mostly at the state level. Next one. So taking example of one of the states where what happens during the interfacility transfers is some of these interventions like taking care of the oxygen, body temperature, fluids, continuation of the medication. And then I also want you to focus on the destination hospitals, 99%, which are all in the public health sphere. But in some of the districts where the travel time is beyond a certain limit, and a few private hospitals, which are all part of the empaneled, they will be the destination hospitals. Otherwise, it is mostly the public health institutions because the beneficiaries are also from the lower socioeconomic status. Next one. So fortunately, with the technology what we have been using, everything what we do in the neonatal ambulance in the form of an interfacility transfer, it is all captured in the electronic pre-hospital care record, and we'll be able to access that and ensure that the full data, clinical manifestations and the changes during the transportation. And then fortunately, we also have a qualified doctor sitting in our state level emergency response center who would also be able to guide the paramedic in the ambulance in all critical situations. Next one. So at the beginning, we have been running these neonatal ambulances for the last 12 years. About 12 years back when we started this, we have created not only a conceptual paper, but we are also envisaged that how much it will benefit at the national level. And we have used a word called mega plan because at the time also we are focusing on the interfacility transfers, while we have another set of large fleet of ambulances called basic life support ambulances, which are public access. And we recommended that interfacility transfer should be available for every district. And in other words, about 650 at the national level in our first paper. In the second paper, what I have cited here, where 1 million pediatric transfers were examined in a retrospective study, we found that the neonatal component is not as significant as we found in comparison to the morbidities or the complications they face in terms of the numerators. Next one. One can go through that in detail offline. I also want to highlight at the national level, India Newborn Action Plan policy is there, and it also encourages the availability of newborn ambulances, exclusive neonatal ambulances from one facility to another facility. Some pictures of the facilities are shown in this particular picture on the primary, secondary, and tertiary care health institutions in the neonatal care segment. Next one, please. I just wanted to brief in the limited time available that India in health states are showing a lot of interest in having exclusive neonatal ambulances. I'm sure that at this point of time, 3 states, by the end of this year, we will have another 3-4 states coming into the neonatal ambulance domain. And the trainings are also standard. So transport protocol, treatment protocol, communication protocol, and documentation protocol are getting standardized. We foresee a very optimistic next 3 years. In addition to the universal interfacility transfers at every district in India, we also have an opportunity that exclusively trained neonatal paramedics may be available with those competencies through an educational and a training related programs. And we will also be able to use the 5G technology for a better medical control. And as such, we have initiated this pre-arrival intimation to the destination hospitals, but we wanted to use Internet of Things and see to that the notification is in place. And finally, the basic life support ambulances, which are having public access, will also have a set of equipment, consumables, and some competencies for the high-risk newborn at the community level, at least by 2030 is what an optimistic scenario is there. So though we are running large network of 20,000 ambulances, at this point of time, we have only 100 plus neonatal ambulances, but we are confident that states will also encourage this, and we will have these IFTs for high-risk newborns to a right high-risk newborn to the right hospital is something India will be able to see in the next 3 years. These are all a few points I thought I would bring it to your notice and attention at this point of time. We are not hovering at 30 minutes across all the interfacility transfers, and I'm sure there's another area where we will all be closing in the coming years. Thank you so much for your attention once again. Over to you.
Thank you so much for Dr. Rao. And I would really urge people to read those papers and to look at that. I think India is so interesting. And this example is the public-private partnership. So the public pays for the services, so they are free, but it's provided by the private sector. And it's a very interesting model. And I think also what's very interesting is this example is I think within that we need to think about, we use the word ambulance very loosely. And sometimes an ambulance just means a car that takes people. And sometimes an ambulance has very advanced equipment. So I think we need to think about that. And also, I think what's really interesting that you've shown us is we must always continue to improve. We start with some basics and then we continue to improve. And India is always so impressive in the fact that it's always continuing to improve and show everybody what should be done. Okay, I'm now going to invite Becca Kirby to talk.
Thank you for inviting me here today to the Newborn Toolkit team and to the fantastic presenters who have gone before me. So today's work focuses on small and sick newborns and hospital-based care. You can go to the next slide. And looks where the breakdowns are happening and technology innovation can supplement kangaroo mother care when it cannot be performed. So the next slide. So we'll start with the core problem that we were looking at. So small and sick newborns are often born extremely premature or have congenital conditions, which makes them already more vulnerable and even more vulnerable during transport. So in low resource settings, this is especially severe, where up to 85% of infants may become hypothermic and mortality rates for transported newborns can be higher. Next slide, please. So to better understand this problem, in 2024, we conducted 55 plus interviews across multiple stakeholder types. So clinicians, engineers, innovators, and researchers spanning Africa, the US, and India. And these primary interviews were supplemented with some secondary research, which included a review of literature, existing guidelines, like some of the WHO ones that came into play, and desk research on existing technologies. The interviews were conducted virtually and in person, and were also included some facility site visits in Kenya to provide that holistic view, not just of the technology, but of those real workflows and the constraints and that decision making and context. So next slide, we can jump in. Next one. So what we did was we really tried to map the high-level patient journeys by identifying these three primary pathways. So one was intra-hospital transport. So for example, a baby's born in the labor and delivery room or the OR, and they need to be transported to the newborn unit. A second was from a community to a hospital transport. And a third was inter-facility transport, so transport between hospitals. So a hospital might need to refer to a higher level of care. Next slide. So each of these pathways have different constraints, risks, and different technologies come into play at different points. And kangaroo mother care, or KMC, is the ideal recommendation, but it's not always possible. And so what we were doing was we were seeking to understand where there was pushback. We were hearing people say kangaroo mother care is not possible. Perhaps if the mother was unstable and there wasn't a surrogate available, or where the neonate was required urgent intervention and the clinician needed access. Next slide. So through these interviews, we identified kind of three main transport approaches in practice, in addition to technology, which we'll jump into in a bit. So one was carrying in the preferred kangaroo mother care position, two was personal vehicles, and three were ambulances, and each have their trade-offs. So for example, kangaroo mother care might be very accessible, but sometimes can not be available. And then monitoring and ambulances may be ideal, but it might be expensive. The cost might be higher. Next slide, please. So we did have the opportunity to see some ambulances, and I was really, really impressed with Professor Rao's presentation before, but there was a lot of variability. So some were basic transport vehicles but others had advanced monitoring. Some had incubators available. But the access and the quality were inconsistent. And I think another point here is just to note that this varied not just between some of the countries that we heard from, but also even within counties within the same country. So there was high levels of variability. So next slide. Our focus was really on trying to understand the technology. So what thermal technologies are available today? And so we can see that there's a very wide spectrum. So we use this 4x4 to map it out across these two different axes. So cost and complexity and portability, and to understand where these existing product categories, so these are the types of technologies, not individual brands, fit in this matrix. So in the bottom right, you can see that linens, which mothers are often encouraged to bring to delivery, and thermometers, they're very basic, they're low cost, they're very portable. But in the opposite upper left-hand corner, you can see that incubators and radiant warmers are less portable, since they require mains power. They also consume large amounts of energy and are higher in price. So there's a wide range of technologies in between. So you can see some newer product categories like conductive warmer, there's transport incubators, portable warmers. And again, each technology, we were seeking what purpose does it serve? None of these are perfect. So on the next slide, we have a breakdown of each of these different technologies. So we can see radiant warmers on the next slide. They're great for in-hospital stabilization, but they require significant power, and they're not quite as portable given their size. Next, we can see transport incubators, which do provide that controlled environment, but they're expensive. They can be really complex and difficult to handle. We'd also like to highlight that transport incubators were the technology that was most frequently mentioned in the interviews as a high priority, where access was perhaps limited, but there was a lot of interest in opportunities for further innovation. Next, we can see conductive warmers, which again is a relatively newer product category. They provide conductive heat below or around the patient with a temperature display. So they allow the healthcare worker access to the neonate. They can be transportable, but some do rely on electricity, which can limit mobility. And then finally, portable warmers, which are highly transportable and lower in cost, but challenges could include disinfection and a lack of visibility and access to the baby. So overall, on the next slide, we can see that this is a fragmented solution space, and no single technology works across all three of these scenarios. So it can be complicated as a procurement officer to really understand the technology nuances. And so we decided to go a level further than the pathways of care shown here. So as shown on the right, I know it's very small to see here, but we really went into detail in mapping the patient journeys to leverage and layering on those technologies in those real world journeys to identify the gaps. So where were there breaks? This exercise was really important to understand those nuances and where existing technologies played a role, but where those gaps were, where perhaps innovations or improvements in access could make improvements. So on the next slide, after synthesizing those more detailed patient journeys, we identified 6 use cases, specific again for that hospital-based care where Nest 360 focuses. And these use cases highlight both the intra, and one of the community-based transport options. So what we were trying to identify were the specific needs. So is oxygen access or continuous monitoring needed? And we have on the far right kind of a hypothesis of where different technologies may be a fit within these use cases when, of course, kangaroo mother care is not possible or a break is needed. So on the next slide, where do we go from here? So our next step was really to move from these qualitative insights and to do some more validation on the use cases of what technology is currently being used to help to inform some of those newer solutions and where, again, those improvements might be needed. So in order to better understand those use cases that we identified and what technology is currently being used, we developed a survey. So the link is available here at the QR code, and thank you, Chrissy, for sharing in the chat as well. So our ask is really inviting all of you here today who are passionate about transporting newborns safely, especially those small and sick newborns, to participate in the survey and to distribute it more broadly to your network. So this will allow us to build a more data-driven foundation for innovation, as ultimately those results can help to inform where that new innovation is needed and what those requirements would be. So we've done this in the past through target product profiles, but we know that it varies across the level of the healthcare setting, the different infrastructure, and so we're trying to collect some more information in this survey. So down the line, on the next slide, um, innovation, we can seek to understand where innovation is a priority. So again, I mentioned in those qualitative interviews, we did hear about transport incubators, and in the past through Nest 360, we have developed 16 newborn target product profiles in collaboration with UNICEF, and WHO was involved as well. And we know that these target product profiles can be useful in highlighting those design requirements for future solutions. So thank you, Chrissy, for sharing the link to the target product profiles. The other resource that we have available is the newborn and maternal technology landscape, which can help to compare some of these specific products in the product categories mentioned above. So by brand name, what are the different radiant warmers available and compare the pricing. So to close, we're gathered here today to discuss how transport is critical, but it can often be under-addressed or pose some challenges. So we have identified some technologies that are appropriate in this space, and I will wrap it up and allow time for questions. So thank you for having me here, and please distribute the survey to those who you think it might be relevant to.
Thank you very much, Becca. That was, again, really interesting. I mean, I think it's so complicated in this space because I often work with people who don't even do KMC if they could. So the first message, I always think the messaging is a little bit complicated because KMC is a very good way of doing it. I've seen too many babies being referred cold, not in KMC when it could be done. So I think the key message is KMC is ideal, but when you can't do KMC, these are the key things to be done. So thank you very much for all the presentations. They've all been really great. I've learned so much. I wondered if we have any sort of key questions that what people would like to be asked. Mabuza, are there any key questions that you think would be good to bring from the Q&A?
I think there's a question from Malawi on rural road access, especially in rains, and Dr. Rao had a response to that. Dr. Rao, would you love to go live and give a response to that question?
Yeah, thank you so much. India, and I'm sure many of the participants of today's webinar, the geographical terrain challenges would also be there, and seasonal challenges would be there. Therefore, we have some riverine districts where we have to run some boat ambulances, and there are some areas where we use only to cross the stream. We have identified the ambulance, the four-wheeler ambulance will go there into the bigger ship, and then it will be crossing the rivers there. And in hilly terrains, we use a three-wheeler ambulance in addition to the two-wheeler ambulance. So depending upon the need, and I agree with that, seasonal challenges would be there, but we do not have the all-terrain vehicles at this point of time. India has some delays in terms of emergency response, both in terms of reaching the incident location and to travel time to the destination hospital because of the terrain challenges, particularly with the climate change. We have extremes of rain situations and extreme heat situations also coming up, particularly in the urban areas, which are identified in multiple regions of the country. EMS will also be impacted, and we need to be conscious about these sort of climatic change situations. Over to you.
No, thank you very much, Dr. Rao. And I think this is certainly an issue which lots of people are challenging. I mean, there's alternative strategies which are when you know that the roads will be really bad, that you maybe bring women before they deliver to a facility, and then you maybe, I think you're from Malawi, they're waiting homes, which is an issue that lots of countries have done. So I think you often need a multifaceted strategy. There's also in the WHO work some really interesting stuff about community, working with community response when you can't get access to services. So I think I would say that there's a lot of work that's been done on these sort of multiple strategies to try and solve this problem. I mean, some countries use helicopters, but of course helicopters are extremely expensive. Any other questions?
There was a
So there's a
comment.
very thoughtful one on keeping mothers and babies together, especially if the mother is sick or C-section, so in transport and referral.
No, I think I'm sure everybody here will answer that question. I think I would agree with that. I would imagine all the speakers. I think that's a very key principle. I mean, I don't know, Lee, if I'm being a bit unfair, but I think it's something that the emergency care people didn't always think about. And I think it's been one of the things that's come out of the emergency care and the maternal and newborn community working together. It's really emphasizing that importance of keeping mother and baby together if at all possible.
Yeah, I don't think that's unfair. I think it's
Okay.
even simply in my clinical days, my pre-WHO days, it was a common issue. You have one of the two patients and they are incredibly sick, you put them in an ambulance and transfer them, and you worry about the other one later, which is, I mean, it really doesn't make sense when you stop and think about it. At the time, that's what the providers are thinking about, concentrating on that one patient who's at risk of dying. But you have to be very active and purposeful and make these plans in advance. So yeah, it's a really good point. Thank you.
Is there any other of the speakers who'd like to respond on that question? Okay, no. So any other issues that people would like to raise? Was there any other questions that?
There was a comment or question on the importance of incorporating conflict or insecurity aspects in function or referral systems. This is from Alice Rosemini. Perhaps a comment on that from any of the panelists?
I mean, Lee, do you want to talk about this? I know it's something that WHO is always thinking about.
Yeah, I'm not. I was just looking for the comment, so I apologize if I'm answering the wrong issue. But if you're talking about systems that are able to work in secure environments, then it's a huge consideration, and it occupies a lot of people, a lot of their lives thinking about it, and it's the lived reality for hundreds of thousands of health workers across the world. So what we try and do is have guidance that is applicable regardless of the actual reality of the setting. That's easy to say, when providers have to think about their own safety before anything else. But I think we certainly, I'm sure Dr. Rouse also from his decades of experience had to deal with this repeatedly. We think of that. We try and make the guidance and the advice as neutral or agnostic of the setting as possible, so that it can work in those settings. That you end up with less equipment, you end up with less effective communication, you end up with less of a handover and things like that. So what are the absolute minimums that are required? And of course, at WHO, we have a whole side of WHO that's really thinking much more about that than I would see. But yeah, really important point. Thank you.
And just to advertise the transport and referral community of practice, if you go to our website, we had a very interesting webinar last year where we had people from the IDRC who were talking about what to do in northern Nigeria and other conflict settings. So I think, there are people who are working in this field, and if you're interested, we can put you in touch with them. Okay, so I think maybe we draw this to an end. Thank you ever so much to all the speakers. Thank you ever so much to everybody attending. And again, if you're interested in this area particularly, please join the community of practice. And thank you very much.